about 3 different genera in some detail. You guys remember what those 3 genera were? Spirochetes. The spiral-shaped ones. Yeah. So Treponema was one of those genera. Yeah, Lepospira, yeah. Lepospiroterians causes leptospirosis. And then that 3rd genus was the one that Borrelia, yeah. And the thing that causes Lyme disease in the Borrelia genus, the species in the United States that causes Lyme disease. Burgdorferi, yes, very good. And then relapsing fever. You guys remember the species of Borrelia that's associated with relapsing fever, or at least like any of those species? Recurrentis. What about the vectors for relapsing fever? Yeah, so vectors plural, soft ticks for the endemic form, and then the one for the epidemic form of relapsing fever? The louse, human body louse. Good. Okay. There was also an interesting question yesterday, which I had to think about. One of you asked me about syphilis. So that's caused by Treponema pallidum. You remember? The question was, so you're contagious during primary and secondary syphilis. You're shedding the organism. During primary syphilis, you're shedding it from those chancres, those genital reasons. So it's mostly like an STI. It's transmitted that way. During secondary syphilis, the rash itself has some of those spirochetes in it, treponemes. So the question was, can you transmit, how is that transmitted during secondary syphilis, and how does that present to the patient who gets it, not through sexual contact? So I looked that up. I'd never thought about that or even asked that question before, but it's a good question. And what I found online is if you do get I didn't find this in the textbook, but if you come into contact with somebody who has secondary syphilis and that rash, that widespread rash, and you have an open cut, you could contract it, it could be shed and transmitted into that open cut, and then you could develop primary syphilis at that site. So the chancre would be wherever that cut was that was exposed to that organism. You could get a chancre on your hand, you could get it in your mouth, you could get it in any number of sites in the body. So, did not know that. I don't know how common that is, but apparently that is possible. So, very good question. And then with bacillus anthracis, when we started talking about our first gram-positive bacillus yesterday, you guys remember what some of the toxins were associated with bacillus anthracis? Uses. Lethal toxin is one of those, yeah. Kill cells. And then the other one, not getting too much in depth on the mechanism, but the other one is EF stands for edema factor or edema toxin once it's expressed. And both of those need PA, protective antigen, in order to have an effect. The 3 routes of transmission for anthrax, the 3 main routes of transmission. Gastrointestinal, yep. So ingestion, cutaneous, and pulmonary, yeah. Which is by far the most common these days? Cutaneous. And what are the risk exposures? What are the occupations, I should say, what are the occupations associated with anthrax transmission? Ranchers, large animal pets. What's the animal reservoir for anthrax? Yeah, ruminants, grazing animals that are grazing on grass that could be contaminated with those spores long term. You get it. What's the form of anthrax that is considered to have just about 100% mortality if untreated? GI, gastrointestinal, and what's the rarest form in humans? GI also, yep. Very good. Let's say you have pulmonary anthrax. Is that transmissible from person to person? Not really, because where is that infection going? Is it in your lungs or is it in the lymph nodes? It's in the lymph nodes. Now, would I want to be next to somebody who has pulmonary anthrax? Probably not. But It is in the lymph nodes, so it's not something they're not breathing it out, and it's not in the lungs. It's in the mediastinal lymph nodes. Okay. So the primary route of exposure is not person to person, it's inhaling those spores from some sort of either environmental source, like or handling carcinal practices that have it, or some bioterrorist event like that. Okay, so we'll finish off the rest of this deck, unless there are any questions left over from yesterday. The good news about starting off with the Clostridium genus, and I still sometimes call it Clostridium, even though it's been reclassified to Clostridioides, is that this is easy, relatively easy to study for stuff. It's all very distinctive presentations. Yes, sir.
I have kind of a dumb question about pulmonary anthrax.
I'm sure it's not them.
So apart from the fact that it's, so the spores are getting into the intestinal lymph nodes, is part of the reason that they can't disseminate to the pulmonary tissue, just like they're stuck there. The lymph tissue is the side of the spores are very large by comparison to other cells. And two, like the lymph nodes are kind of fibrous, and so it's going to get away.
Yeah, that's a good question. So here's my understanding of the pathogenesis of pulmonary anthrax. What you're inhaling in is spores. They get into your air sacs, and then they get phagocytized by alveolar macrophages into the lymph nodes, into the mediastinal lymph nodes. By that point, the lymph nodes, that's a good place for them to be. So they will germinate into vegetative replicating cells in the lymph nodes. And there, remember that incubation period during primary, like the initial stage of pulmonary anthrax is 1 to 6 days. During that period, that's when you have germination of vegetative cells, and then you have reproduction of the bacterial cells, and then you have toxin production, so production of edema factor and lethal factor, and that's when you start getting some of that really serious pathology associated with pulmonary anthrax. Huge swelling of those lymph nodes, chest discomfort, respiratory distress, stuff like that. But most of those bacteria, even though they're vegetative, they're not going to be in the lungs at that point, they're in the lymph nodes. And then from there, you can have those bacteria that are replicating get out of the lymph nodes, and you can develop like a more distributed, disseminated form as well. That's possible. You can get meningeal involvement, they can invade, they can get into the bloodstream, so they can expand from pulmonary cases. If you survive the insult and the injury that's going on localized, you can get an even worse infection if they get outside of that area. Great question. Okay, so start off with Clostridioides, which was renamed, I think in the last decade or so, like I said, I still call it Clostridium. These are very large anaerobic spore-forming gram-positive bacilli. They have usually either terminal or subterminal spore formation. You can see that there, unlike bacillus thuringiensis. They do well in oxygen-limited environments, so they do well in deep wound infections. A lot of these that we'll be talking about, some gastrointestinal infections. Some of these species that are associated with specific types of diseases, the route of entry and the reservoirs where they are naturally play into the types of diseases they cause in the human population. So it's kind of important for us to hit upon the ecology of these different species. And we'll go over all 5 of these, all 4 of these, plus a bonus, a couple of species, Septicum and Sirdelii, when we're talking about gangrene, but mostly Purkinjeans. Those are the 4 main species that we're going to be talking about that are serious human pathogens. Okay, these are among the strictest anaerobes that affect the human population, and because of that, when you guys suspect that somebody has a clostridial infection or an infection that's involving an anaerobic site, like one of these specimen sources, for example, making sure that the amount of oxygen that specimen is exposed to is critical in terms of the lab's ability to recover any viable organism by the time it arrives in the lab. So we have special anaerobic collection processes to make sure they don't get exposed to oxygen. Normal atmospheric oxygen can kill these guys within minutes, so it's really, really important. There's always PCR if the organism is no longer viable, but you don't want to rely on that, you still need to culture. So if you've ever seen one of these guys before, this is one of several different systems we have for transporting specimens and for incubating plates under anaerobic conditions. This is a gas pack jar where it has like A plating catalyst and pH indicator and the ability to reduce the conditions in that jar and make sure it's anaerobic. If it's anaerobic, there's a pH indicator, or there's a color indicator in there that'll tell you that you've reached anaerobic conditions. There's a very good seal in there, a gasket, to make sure air can't get into that container once you put your specimens in there. So timing is very critical. And going back to some of these specimen types, this is not a comprehensive list, but just some of the specimens that we would associate with anaerobic infections. Things that could be associated with Clostridioides and other genera like Bacteroides, for example. So we can culture these organisms. They're not particularly fastidious, assuming you're able to keep oxygen out of their incubators. We can culture them. They have some pretty distinctive morphologies when they grow up, oftentimes. We also have toxin tests for organisms like Clostridioides difficile. Test those toxins in stool. And for Clostridioides botulinum, we have a toxin test for that as well. Alright, the first one we'll start off talking about is C. diff, Clostridioides difficile. This is one of the most concerning bacteria clinically, especially in hospital settings these days. Increasingly, we're seeing infections out in the community as well, but what is primarily associated with Clostridioides difficile are conditions that are dysbiotic in the gut. So you can tolerate being colonized to a certain extent with Clostridioides difficile. It's not really a beneficial bacterium. But 5% of healthy individuals will carry this bacteria. But the problem arises when you treat people, usually for unrelated problems like UTIs, respiratory tract infections, with broad spectrum antibiotics, wipes out their natural flora, and it causes organisms like Clostridioides difficile to overgrow, and then you get pathology and tissue damage as a result of that. In terms of acquisition, it's possible to have this either develop as like your own endogenous flora, an overgrowth of endogenous flora, or you could be hospitalized and acquire spores from the hospital in that setting, since there would be other people there who might be shedding Clostridioides difficile. Because as a spore former, very, very difficult to get rid of. And because of that, when patients are known to have C. diff infections, CDIs, usually they will put them in under contact precautions, which means you have whatever possible dedicated equipment, so like blood pressure cuffs that are dedicated for that patient in that room, stethoscopes that are dedicated for that patient. People coming in and out of that room, the providers coming in and out of that room to treat the patient, will wear gowns, they will wear other PPE to make sure as much as possible they can shed that when they leave and not transfer spores from room to room, patient to patient. That's how problematic this is, because it's a spore former. In terms of the types of patients who are mostly impacted by CDIs, it is definitely a disease that skews towards the older population. These are people who oftentimes are hospitalized at higher rates. They are given antibiotics a lot for other infections that are going on. So this epi chart right here, this graph that we're looking at, are the general cases of CDIs, not stratified according to severity or anything, just general cases of CDIs per 100,000, stratified by age. And you can see the majority of patients are over the age of 85, which is pretty advanced age. But if you look down into some of these younger strata, these are still significant high levels of incidence, and it's not impossible for people in their 30s, 40s, and 50s to get CDIs and to potentially get life-threatening disease. So, significant problem. There's a heavy resistance to fluoroquinolones, so that's something to kind of keep in mind. As I had mentioned, hospital-associated infections, they might be decreasing generally, especially as people get better at handling contact precautions and isolating patients with it. But out in the community, it seems like the incidence of CDI is increasing. Anytime you have a disease that requires isolation and prolonged hospitalization, hospital costs increase. So this is substantial, about an estimated $1 billion in economic impact because of C. diff infections. diseases that are associated with Clostridioides difficile infections, ranging from mild and something that you may be able to correct with probiotics or removal of antibiotics as soon as possible, as soon as you possibly can, all the way up to super life-threatening conditions like pseudomembranous colitis and megacolon and some other diseases that are, have high mortality rates associated with them. This is just a kind of a generic term, antibiotic-associated diarrhea. It doesn't really talk about the severity of the disease. It just means that you get that condition caused by the use of antibiotics that wipe out the normal flora. So you'll hear AAD periodically. Typically, when you have a broad spectrum of Lyme patient, if they're going to develop CDIs, this will occur within 5 to 10 days. That process of slowly transitioning over to C. diff. And you can try and treat it. You might treat it empirically and not know that it's C. diff. When those bacteria come into contact with antibiotics, that could be received by those bacteria as a harsh environmental condition. So what might that trigger in spore-forming bacteria, do you think? Sporulation. So the gut bacteria, they can sporulate. The rest of your gut flora cannot. So you have these sporulated pathogenic bacteria in your gut. As soon as you relieve, or as soon as you stop the antibiotics, they can go back to germinating, and then you have the same problem over and over again. So that contributes to something we call recurrent C. diff infections. Just have a very, very frustrating, hard to treat problem, but it happens over and over again. Sometimes these spores that survive will germinate in a healthy gut and just cause the entire problem over again. And sometimes they'll germinate when the gut is still extremely unhealthy, and that contributes to an even worse situation for that patient. Either way, again, very difficult to treat, very concerning issue that we have. Pseudomembranous colitis, or PMC, is one of the more serious manifestations of CDIs. This is caused when you have these bacteria that are germinating in the colon, and because of toxin production, they have causes a lot of diarrhea just naturally, but it also induces a lot of necrosis in that tissue. So you can see here, this is a visualization, probably in a colonoscopy. With that scope in there, you can see some of this tissue with white or yellowish plaques that have formed over the intestinal epithelial cells. There's a little bit of bleeding right here. So this is a lot of just damaged tissue, basically. You would also have dysfunctional ability for the gut to behave like it normally does, reduced ability to function that contributes to the diarrhea. That can lead to dehydration and other diarrhea-related problems. Electrolyte imbalances, it gets really serious. So, but yeah, this is considered a hallmark of infection. This is typically seen when you do colonoscopies or other techniques where you would have a scope and be able to visualize this tissue. In terms of toxins, we have two toxins associated with CDIs, toxin A and toxin B. Toxin A is a chemoattractant, so it'll actually recruit neutrophils into that area, and that will also contribute to the inflammation in the gut. And then toxin B contributes to the diarrheal symptoms by increasing intestinal wall permeability. Yes, sir?
So, if you introduce antibiotic-associated diarrhea as your first perfection of this disease, the offending drug,
If you can, yeah.
and then the same thing be, or could the same thing be done with the pseudomembranous colitis, or is that just, hey, it's, it's in there, it's seated, it's proliferating, it's got toxins going, there's nothing, well, it's not that there's nothing for it, you just keep pushing the drugs.
There are treatments, and there are ironically antibiotic treatments for CDIs, even antibiotic-resistant strains of CDIs. Metronidazole, vancomycin, certainly if you can avoid fluoroquinolones, that would be something to avoid because that's associated with causing the condition in the first place. But when you guys get to GI, your junior semester, they'll talk much more about this disease and the treatments for it. In this course, there is one treatment that we'll talk about a little bit in a couple slides for for really severe, especially recurrent cases of CDIs, they're having a hard time treating even with metronidazole and vancomycin. But yeah, as soon as if you can culture this and get an identification that this is Clostridium difficile, and that you've identified that this is a problem, step one would be, if at all possible, remove the broad spectrum antibiotics that you're administering to that patient. Yeah, John?
Next question, when they go to spore state, do they lose some ability to adhere? Do they become less adhesive?
That's a good question, I don't know. That's a really good question, I'll look into that. I know, like, the conditions in the colon, sort of slowly talked about, and you guys are all experts on the GI system now anyway, right? But when food is in the colon and just in the lumen of the large intestines, that's slow moving, right? So it's not like it's being pushed out quickly. But the patient also has diarrhea, so yeah, I don't know if how they're able to stay in place throughout that without being able to attach to something. I'll see if I can find an answer for you. Okay, so this whole slide on controlling CDIs. Prevent cross-contamination, strict infection control measures, that's what I was talking about with contact precautions if at all possible, dedicated rooms, etc. Antibiotic stewardship, discontinue the triggering antibiotics. Supportive care is big, just like when we talked about with Vibrio cholera, patients are using a lot of fluids, you have to make sure that their fluid levels are maintained. So that's life-saving in a lot of cases. Probiotics. So a lot of research is actively being done on the use of probiotics to treat CDIs and other intestinal imbalances, IBS, IBD, things like that, Crohn's disease. There's not a lot of really good firm evidence, but it's an active area of research, so some providers may look into providing probiotics as well. I mentioned that there was a therapy that's used when you really have no other recourse and the infections aren't responding to antibiotics like metronidazole and vancomycin. There's a technique that is becoming increasingly popular called fecal matter or fecal microbiota transplantation. That's so that's been fairly successful, and what that whole idea or concept is that when you have a dysbiosis in someone's gut and they're unable to restore the natural balance of the bacteria themselves, you simply repopulate their gut bacteria by using the fecal matter of somebody who's healthy. Okay? So that can be done by a couple different ways. I'll come back to lab identification. Yeah, actually, let me come back to this slide in a second when we'll talk about FMT in more detail. Yes, sir, go ahead. Yeah, exactly, yeah. The very last organism we talked about today is Bifidobacterium. And there are many others like Bifidobacterium, but the role of these healthy bacteria we've talked about in the gut is a couple things. We talked about aids in digestion, nutrients, vitamin K, vitamin D synthesis, all this good stuff, but also in occupying those niches in the gut mucosa so that you have enough competition to keep bad ones to a bare minimum. As I said, you can be colonized, 5% of the population is colonized with C. diff, but they don't progress to disease because they have enough good bacteria and it's imbalanced to keep them in check. Okay, so with FMT, as I said, what happens here is you're providing that patient who has a dysbiotic gut with normal flora. There are some issues and problems with this, of course, as one might expect. Most of them relate to quality of the donor stool. It's coming in, but there's a lot of really rigorous screening that goes into that. I had a student 3 or 4 semesters ago who claimed to have been a donor. I don't know if I believed him or not, but you do get paid, and it's just, if you're a donor for stool, I know this from just looking it up, you have to go through some really rigorous screening questionnaires, and then there's extensive health questionnaires, and then they test your stool itself for Salmonella, Campylobacter, E. coli, the pathotypes of E. coli, a bunch of different viruses, some parasites, mean, they tested it exhaustively. And then your own health behaviors, your age, all of that, drug use, sexual behaviors. I mean, it's like an extensive thing if you want to be a still donor. But
How much we pay?
I don't know. I don't know. My research didn't go that far.
I got you.
Maybe, I mean, maybe there's some direct competition, but more it's just getting bacteria that aren't going to be pathogenic to you to restore that balance. Yeah. So when you have this fecal matter, what these various formulations, whether they're liquid or whether they're lyophilized like these pills, what they all have are good gut bacteria, normal gut bacteria, like bifidobacterium, like lactobacillus, and other genera like that. There are a couple ways to get it into the recipient. One of those ways is basically through like a colonoscopy, where you sedate that patient, and since you're repopulating the colon anyway, I guess you don't have that far to go, but you know, that's one way. Another way is this nasoduodenal tube, where you stick down that person's throat. There's been cases where there's something's happened and they've aspirated and got pneumonia. Sorry, but yeah, like how horrifying is that? Yeah, thank you, Matt. Yeah, and then there's a third way that's not even on this, but that's this pill form here, which if it were me, I would opt for that. So the only problem with that pill form is you have to take, the way it's formulated, you have to take like 30 or 50 pills sometimes for the desired effect. So I don't think pharmaceutically they've quite mastered that one yet.
Just so you know, man, you make $180,000
About 1,500 a month.
depending on your poop. Get your poop approved.
If you got great food, you're good to go.
Full-time business.
Okay, so that's interesting to know. For you starving PA students out there, if you want to supplement your income. Yeah, so yeah, he set up like 180K a year donating to school. If you're super healthy and you have a okay.
Shitloads of it.
Okay, a couple more points on FFT. So the main hitch is screening, but otherwise this is becoming increasingly popular. 89 to 90% effective for patients who fail antibiotic treatment. So they're reserving it not just for any old person who feels that they could be dealt a better hand with their gut microbiota, but really severe cases. And in those really severe cases, the efficacy so far has been pretty good. I have the data, I think, on the number of FMTs they did last year. Yeah, 48,000 FMTs were done either last year or the year before, which was about, that's a lot of procedures. 10 to 15% of the total cases were treated with FMT. All right, let me just go back and hit diagnostics on this slide. So we do have those two toxins that we had mentioned, toxin A, toxin B, and there is a nice rapid test that you can do, an immunoassay. You add that specimen to this membrane, and you get an indication if you have that organism, or if you have toxin, I guess, more specifically, in that stool specimen. We have PCRs as well, to see if we can detect the genes that encode those toxins. And then, again, assuming you can culture it under anaerobic conditions, then culturing that organism and identifying it through traditional culture is also standard. All right, the next organism we're going to talk about in this genus is Clostridioides perfringens. This is potentially a really nasty bacteria. It can do a lot of terrible things, but it also is responsible for some fairly run-of-the-mill gastroenteritis as well. Very common source of just normal diarrhea that you could easily mistake or E. coli or salmonella or something like that, or Campylobacter. Depends on which of these types of Clostridioides perfringens you get. So we'll come back to that in just a second. In terms of the epidemiology, just like when we were talking about other species of Clostridioides, this is a soil bacterium as well, at least some of these types of C. perfringens or soil bacteria. Others are more associated with sewage, and still others are oftentimes implicated with being carried in animal intestines. So each one of those sources is important for knowing how you might contract the disease caused by Clostridioides perfringens. It is a pretty rapid grower if spores that contaminate food from the environment get into food. So if the spores get into food, and if it's at the right temperature, between 40 to 149 degrees Fahrenheit, that danger zone, they will germinate and they will grow to great numbers in the food that you eat before you eat it, and that can lead to diarrheal disease. Very, very common, like I said, there's a spike around the holidays, generally when people get together en masse and they're consuming a lot of leftovers that haven't been properly refrigerated or just kept at the right temperature. And then you get whole families sometimes that come down with food poisoning from Clostridioides perfringens. Another more famous disease that's associated with Clostridioides perfringens is gas gangrene. This is like the classic cause of gas gangrene. Although septicem and Sordellii can also cause gas gangrene, very indistinguishable symptoms basically. In terms of those types, we have 5 different types of bacteria in this particular, that belong into this, in this species. And these types determine what types of disease, or they're linked to different types of disease caused by Clostridioides perfringens. Types B through E are not found in the soil as much as type A is, but since they can colonize the GI tract animals, you can get that with some of those foodborne diseases. Type A strains are associated with soft tissue infections and food poisoning. And type C is linked to another really, really virulent disease called enteritis necrotans. There are a lot of toxins associated with Clostridioides perfringens. I know this is a lot to handle, but I would ask, just, you don't have to remember all of these, but there are some that you need to hone in on and remember before the test. First, it produces some of these normal histolytic enzymes that we've been talking about, these invasive enzymes that contribute to tissue damage. So the collagenases, the DNases, the lipases, lucifinases, hemolysins, those just normal invasive enzymes. C. perfringens produces a lot of those, and that contributes to a lot of the tissue damage. You can see that on a plate where they have some colonies of C. perfringens. This produces a couple different hemolysins, so you get a double zone of hemolysis around those colonies. You can see that. In terms of the major lethal toxins, the one that is most important to know is alpha toxin. Alpha toxin is basically a phospholipase or a lucifanase. Very broadly destroys cell membranes, so that contributes a lot to cell death and hemolysis. When we're talking about gangrene, even though all 5 types of C. perfringens produce it, this is the one that contributes most importantly to the pathology of gas gangrene. Beta toxin is probably the second most important one. This one is associated more with necrotizing enteritis types of C. perfringens, so it's produced by the C-type organisms, and it does damage to the intestinal lining. And then epsilon and iota, both of these will do tissue damage as well. Epsilon will damage or affect vascular permeability. Iota will interfere with membrane permeability and also contribute to tissue damage. And there's an enterotoxin that's produced by this really concerning strain, the type A bacteria that has superantigen activity. So if you remember superantigens, that will contribute to some of those systemic effects, fevers, inflammation, things like that, cytokine release, uncontrolled cytokine release. So that is more associated with food poisoning, enterotoxin food poisoning. I put a picture of a gene map for C. perfringens on there, just not for any other reason other than to underscore the point that these different types carry different genes for these different toxins. So some of them will have bigger genomes than others, but not all types carry the same genes in the first place. So that has like an intrinsic impact on their virulence and the capability that they have to cause these different diseases. In terms of the diseases that can be caused, for gas gangrene, also known as myonecrosis, this is probably the most severe form that's caused by Clostridioides perfringens. Type A types of Clostridioides, as well as these other species, can cause this really oftentimes fatal manifestation of an infection. You can also get these less severe but still really dangerous forms of tissue infections, cellulitis, spreading subcutaneous infections that you get that are oftentimes red and need to be treated, suppurative myositis, where you have muscles that are infected, and then myonecrosis is where the muscles are being killed. With gas gangrene, that term, why do you think it's called gas gangrene? There's a lot of gas. Yeah, it's just a metabolic byproduct of those bacteria that are reproducing in your tissues at very quickly at high rates. So they produce gas, and because of that, some of these symptoms are associated with that. Crepitus, for example, hallmark symptom, it's when the gas production is so noticeable that it becomes audible, and you can hear that popping noise in those tissues where gas is located. Imaging studies are really important to diagnose gas gangrene, although you can probably just diagnose it based off of the presentation. With imaging, you can see the gas in MRIs and other images. You can see the gas starting to form in these pockets in patients who have these deep tissue infections. Severe pain, that goes with all three of these presentations, pain out of disproportionate to the extent of the damage that you would think just visually looking at that patient, until or unless the bacteria invade all the way down to the nerve endings, and then the patient stops feeling pain. This discoloration and the formation of these vesicles called bulli are very common with gas gangrene as well, common presentations. And then this discharge, if you take a specimen of these bulli, or if they rupture on their own, the discharge is this brown, viscous discharge, has a characteristic sweet smell to it, and there can be some sulfur smell that is associated with this as well. Sometimes it's described as a barnyard odor from those, the bulli. And then systemic toxicity. So all of this leads to a pretty serious clinical picture. For treatment, debridement, aggressive antibiotics, broad spectrum, in this case probably broad spectrum antibiotics. Some of these gas gangrene cases are polymicrobial, so you don't have to treat just C. perfringens, you might have to treat several species that are contributing to this infection. Very difficult to treat. By way of quick review, back in the first couple decks, we were talking about another bacteria that's associated with necrotizing fasciitis. You guys remember what that was? Streptococcus pyogenes. Yep, very good. So that's another bacteria that's considered to be flesh-eating, but has some features that are a little different than gas gangrene. And then we also talked about another bacteria that was a gram-negative, and it had a gull-shaped morphology, if you were to look under a gram stain. This one was associated with people who go out into brackish waters, warm waters, who have an open cut somewhere. They acquire it through that wound. Vibrio vulnificus. Yeah, so Vibrio vulnificus is another species of bacteria that can cause massive tissue destruction, flesh-eating bacteria on the scale of this. But this organism is sort of famous, big contributor to amputations and deaths during the Civil War. We don't have good numbers on how many people or soldiers lost limbs or lost their life to infections due to gas gangrene, but a significant number. I mean, the hospitalizations and the procedures themselves were pretty crude, so the survival rates were pretty low for patients who got gas gangrene. And this would also set in really quickly too, because it is a rapid growing organism. Once it gets into deep tissue, in anaerobic conditions, so deep tissue infections. When you collect a specimen for Clostridioides perfringens, it's important not to get a superficial specimen because A, you'll probably get contaminating bacteria, and B, these guys are usually found deeper in anaerobic tissue, heavily damaged tissue that's ischemic anyway, that is under-oxygenated as well. A couple other presentations associated with Clostridioides perfringens. We have the food poisoning form. Like I said, this is sort of your run-of-the-mill food poisoning. This is associated with spores that contaminate your food, germinate, and then you ingest those bacteria, and you get pretty rapid onset of diarrhea. This is usually self-limiting and will resolve on its own without antibiotic treatment. I don't want to say it's not a big deal, but compared to these other presentations, it's not quite as severe. But it's extremely common, and we do have tests for Clostridioides perfringens food poisoning. Yeah.
Of the food poisoning, so Staph aureus typically has, acute food poisoning as well because they're preformed.
Yeah.
Is that more rapid than this? These aren't preformed, right?
That's a good question in terms of like the onset, the rapidity and the onset. Inoculum would have something to do with both bacteria, like the size of the inoculum. But any time you have a bacteria that has preformed toxins, onset will be faster. Because type A has alpha toxin and enterotoxin, that's a pretty rapid onset. 8 hours is pretty fast. Not as fast as B. cereus, which is also toxin mediated, we talked about the other day, with the emitted form happening really quickly, like super rapid onset, sometimes within an hour or so. But yeah, 8 hours is pretty rapid onset. And there are definitely toxins at play with this. But just to underscore that point, the bacteria themselves are also playing a role in that pathology of this diarrheal infections. It's not strictly toxin mediated. The presentation of enteritis and necrotins is another one of those really serious life-threatening diseases. It's extremely rare. We don't see it a lot in this part of the world. It's associated with people who have malnutrition or protein-poor diets. So the highest incidence is in Papua New Guinea, where that's how it got the nickname pig bell. It's a pidgin word from pig belly, which is an allusion to like the intestinal distension you get with pig bell. But in Papua New Guinea, they have an extremely protein-poor diet and eat a lot of starches. And like sweet potatoes is heavy in that diet. And because of that, they have a hard time breaking down that beta toxin that's associated with this particular type of infection. So we do see cases occasionally, but not a whole lot. What's involved in terms of the pathology is just a huge necrotic destruction of the jejunum, which is that central part of your small intestine, about 2.5 meters wide, gets walloped, just completely destroyed. In this picture here, which I don't know if I linked, oh yeah, hopefully I linked the case report URL. Kind of an interesting write-up, but this was a 6-year-old boy, this case report, who had pig bell in Papua New Guinea, and they had to do a resection on that part of his small intestines, because that was just necrotic tissue, necrotic intestinal tissue. High mortality rates associated with that. Bloody diarrhea, but not common. The last bullet on this slide, Clostridial endometritis. This is associated with gangrenous uterine tissue and other reproductive tissues. Famously and kind of classically, back alley abortions that are done with really like unsanitary, dirty instruments are linked to this particular type of Clostridial infection. And that's when the spores get onto these instruments, and then when they're inserted inside somebody, that reproductive tissue is conducive for them to germinate. So the bacteria will germinate and produce toxins, and you get like just a really terrible infection that's involving the reproductive tract. And that can be deadly as well if it becomes systemic. Let's see. Let's take a 10-minute break now, and then we'll pick up with botulinum.
You're 100%, but I read it because of the way I look at it in relation to like so I guess I'm worried for you.
Well, you know, I mean, framing is everything, like for test purposes, I don't or what is someone telling you?
Or which is most, which is less, because you mentioned here, like, 100% is that, but also.
You need to be on the top deck.
Yeah. That might be, but that's a different phrase than CGI
Okay, yeah, and so I'd be a little,
Yeah.
I guess,
Yeah.
coming in on that.
That is from the textbook.
Okay.
Sometimes I'm not blaming the textbook, but context is sort of lost sometimes.
Sure.
Love to be better at making these points.
Okay, so that's just how they protect you. Because yeah, like, inhalational is usually associated with
Yeah, I mean, these days, yeah, but, historically, not so much.
Yeah.
Right? Because that is like, so I don't want people to only associate with very anthrax. But yeah, if we're so good now.
would an otherwise like non-endemic area.
Yeah. New York City. Yeah.
That's what I keep in mind.
NBC, right?
Right, yeah, okay.
Yeah.
Yeah. So it's actually funny because there were two cases of like
Yeah, I've seen like the people out I had to do a money order when I got the injury because so I usually use that for yeah, I just was like, I got more recently. There's like 30 minutes when I first got there.
okay, yeah, so we were there, But I said, so like the if you have yeah.
Yeah, there's like multiple decks.
But if
So like now I gotta.
But you
Hey guys. Back up again. Alright, so we've got Clostridium botulinum. Famous for producing one of the most potent neurotoxins known to man. Botulinum neurotoxin, abbreviated here is BONT, Botox, Botox, a bunch of names. But what this toxin does when this organism produces it is basically binds irreversibly to the terminal of these neurons, and it blocks the release of acetylcholine at that neuromuscular junction. So when it does that, that causes a flaccid paralysis, and this is an irreversible thing. So there are some treatments and modalities where you can prevent the toxin once it's released from binding to those receptors, but once it's bound to the receptors, there's no way to reverse that binding event. Okay, so that's important. In terms of release, when we were talking about toxin release, especially with those gram-negative bacteria and their secretion systems, 1 through 6, a lot of type 3 secretion systems. With Clostridium botulinum, they do not have the same type of system. They're not secreting these toxins. They actually, usually they'll start producing them in high numbers or high amounts, high volumes of toxin. And then the cell bursts or lyses, so they release a lot of toxin at that time. So this is predominantly a toxin-mediated effect. There are a bunch of different presentations depending on the route of entry or exposure type to these toxins. But in general, their symptoms appear within 18 to 26 hours after exposure. May not necessarily just be ingestion, so it's a little broader than that. But there's a mnemonic or way of remembering that. The 4 Ds associated with botulism. Diplopia, which is double vision. Dysphagia, which is difficulty swallowing. Dysphonia, a hoarse voice, and dysarthrigia, difficulty speaking. So the 4 Gs. In addition to those are some of the early indications that you have flaccid paralysis.
Then can you say all 4 of those again?
Yeah, sure. Diplopia, that's the double vision. Dysphagia, difficulty swallowing. Dysphonia, hoarse voice. And dysarthrigia, difficulty speaking. So those would be, usually these symptoms sort of start top down. So the difficulty swallowing, difficulty speaking. And then if you have a sufficient enough dose of this neurotoxin, some of the more severe presentations are you can get paralysis of the muscles that control your rib cage muscles. You can get control of your breathing, so you can get respiratory paralysis. If you have cases that have fatal outcomes, that could be one cause of mortality, respiratory paralysis. Blocking of acetylcholine release. In terms of those presentations, classic one is foodborne botulinum. What do you associate with this form of botulism? Home canned foods in particular, but could be store-bought as well. How do you know, or is there any way to suspect that?
Bulging cans.
Bulging cans. Yeah, and that's exactly. So that's caused by the organisms themselves. Sometimes because these are soil bacteria, they might get into the. Shouldn't pick on a particular type of food, but let's just say green beans. Just popped in my head. A can of green beans gets in there. The spores are able to ferment the carbohydrates in that can, and they germinate. So they do well, and they start releasing a lot of gas, and that gas is forceful enough to actually warp the can, a metal can, and cause it to be convex at those ends. So that's kind of classic, but also people who like to do home canning for their own vegetables. A lot of cases are associated with people who do home canning. recommend that you boil for 10 minutes after you, when you're ready to eat something. I don't know what that does to the flavor profile, but that's the recommendation in order to destroy that toxin. So mortality rates here, 15% due to respiratory paralysis. I don't have numbers on how frequent we have cases of foodborne botulism. Infant botulism is another form. This is associated with the ingestion of spores, oftentimes in honey or infant formula, when the spores get into those food sources. When the babies consume those food sources, they will germinate in the infant's intestines, and you get symptoms like feeding problems, constipation, lethargy, poor muscle tone, and most famously floppy baby syndrome, which is what we're seeing with this baby's head is kind of unnaturally flipped over on the side like that. I'm not an expert or a pediatrician, but I don't think they're supposed to look like that. The reason why infants are so susceptible to that is because they don't have a very diverse gut microbiome at that point in their life. So an adult would be able to probably withstand that, but infants not so much. They also don't have a very effective immune system. This has been linked to SIDS, sometimes it's some infant death syndrome, mysterious etiology. I don't know how clear that connection has been made, but it has been associated with botulism in infants. Another form is wound botulism. The spores get into an open cut in the skin, germinate, and produce botulinum toxin there. And then adult intestinal toxemia botulism, very, very rare, but these will, this is when the spores will germinate in the adult intestines. And then we have iatrogenic botulism. What does the word iatrogenic mean? It's what? What'd you say? Sorry, I can't hear you. Caused by what? Healthcare, yeah, seeking healthcare. So this, in this particular application, most of you are aware of the cosmetic use of Botox, right? To help get rid of wrinkles, pay a lot of money to have units of, purified pharmaceutical grade Botox shot into wrinkly areas in your skin that relaxes the muscles. There are a number of things that can go wrong though in that process. You can overdo it and add too much. You can hit the wrong spots. And in those cases, you can get something like iatrogenic botulism. This poor guy, there's something up with his eyebrows, I'm not sure, and he has drooping eyelids as well. It's called ptosis. But in these cases of iatrogenic botulism, this is not medically significant usually, but it does kind of suck that you just paid all this money and you're stuck with this irreversible nerve blockage. However long it takes for those nerve endings, the terminal of these nerve axons to regrow, that's how long that person's going to be stuck like this. There's not really anything you can do to reverse that. But on the positive side, you're not going to get respiratory paralysis either, most likely. So, not to minimize the use of Botox, it's also used for some non-cosmetic things as well that are really important, and facial tics, other things like that. I think we use Botox for those as well. Migraines, yes, whoever said, did you say that? Yeah, migraines, that's another one. I don't know how that mechanism works, but I've heard of that as used before. As a bioterrorism agent, there's a lot of attractive features to using Botox, surprisingly, but you can acquire it easily, you can mass scale it, relatively easy to disseminate because you'd be disseminating with the spores, and it is extremely potent as a neurotoxin. In terms of interventions, if you've ever, especially for infant botulism, there is one treatment that I mentioned. It's an immunoglobulin treatment where, if an infant has signs and symptoms of botulism, they can give you Baby-Vig, which is an immunoglobulin passive immune therapy to help block any toxins out there from binding to those receptors, those neuron endings. But in order for that to be effective, you have to administer it before that toxin binds neurons in nerve endings. In terms of detection, we can detect the toxin itself in serum, we can detect it in stool, food samples. We can culture the organism from wound or from stool specimens. And then we have rapid assays like ELISAs as well, which may have varying degrees of sensitivity. We have Clostridioides tetani. This is another famous presentation. Kind of the opposite effect of botulism. This causes a spastic paralysis. Very painful. The most famous symptom is lockjaw or trismus, where the masseter muscles will contract and you won't be able to open your mouth, basically lockjaw, like this guy in the top picture you can see. It's called Rhizus sardonicus or sardonic smile. Very painful though. Generalized symptoms beyond lockjaw are this muscle rigidity and spasms that can be triggered by things like not just touch, but light. Sounds sometimes can trigger these spasms. And the whole body is affected. You can get really extreme spasms like this child right here, whose back is flexed at this really unnatural angle, or this adult, you can see the muscles that are tensing up down to the toes curling. Very painful condition for those people. We only get a couple hundred cases. We don't get it very often in the US. Why is that? Why do we have so few cases of tetanus? Yeah, so this is the T and DTaP or Tdap, those vaccines we talked about. What you're vaccinated against with tetanus is the toxin that it produces, tetanus toxin, that will bind to those inhibitory or bind to neurons and block the release of inhibitory neurotransmitters, GABA and glycine and others like that. So the vaccine is a formaldehyde-treated tetanus toxin that stimulates antibody production and allows you to clear those toxins before they bind to those neurons. In terms of diagnosis, because the symptoms of tetanus are so distinctive, this is one disease that's usually diagnosed pretty easily based on empirical means. Somebody's exhibiting lockjaw, sardonic smile, or whole body flexion like that, muscle spasms, especially if they have a known incident, like I stepped on a nail at work the other day, a rusty nail, and I've not been vaccinated against tetanus. You can usually diagnose based on those means. But in terms of the lab, we don't have good confirmatory testing to diagnose that, so empiric diagnosis is common. So that's it for that genus, Clostridioides, last spore-forming bacteria. Now we're moving on to some gram-positives that do not form spores, starting with Listeria monocytogenes. We had mentioned this one a couple days ago when we were talking about Neisseria meningitis and Haemophilus influenzae. Anybody remember what the association was with Listeria monocytogenes? Cold cuts, but like in terms of the disease that yeah, meningitis in infant populations and the other side of the age spectrum, extremely old people. So with Listeria monocytogenes, it can cause more than just meningitis, but this disease is sort of associated with populations of interest. Common routes of acquisition, usually this is going to be foodborne. It's commonly associated with cold cuts, deli meats, soft cheese, like hummus I didn't know about, that's good to know. Oh yeah. So the CDC, they just revamped their guidelines for pregnant women, which is one of those populations we're going to talk about, but the types of cheeses specifically that are on the okay list versus don't consume list. And as I said, like soft cheeses, particularly brie and queso fresco, sadly, are, yeah, I know, but they're kind of no-nos because they've been implicated with Listeria monocytogenes. So if you're pregnant, CDC recommends that you avoid those cheeses until after you were done being pregnant. Hard cheeses are usually fine, like Parmesan, other cheeses like that. Before we talk about those three groups of interest, the ability to grow at colder temperatures is something we've talked about a little bit with some of these other bacteria. Some of them were arthropod-borne, and that was down to temperatures of around like room temperature, 25 degrees. But with Listeria monocytogenes, we're talking about much lower temperatures, like refrigerated temperatures, 4 degrees Celsius. So able to grow in that milk or in that cheese that's been sitting at a proper temperature in your refrigerator. That's kind of the scary thing about this, if your food is contaminated with Listeria in the first place. Most people, if they consume food that has Listeria in it, are going to develop non-invasive gastroenteritis. In other words, not that big a deal, self-limiting. It sucks, but it's not going to probably kill you. Healthy people can get sick of non-invasive gastroenteritis. Populations we worry about more are immunocompromised people who can get invasive forms, so meningitis, septicemia, and in that population of immunocompromised people, you can lump older individuals as well because their immune systems start to wane, so they don't have the ability to fight off infection and limit the spread of infection. And then the most important population to be aware of are pregnant women. So going back to pregnant women, the reason why we're concerned about them is because if they acquire this organism through eating something, a dairy product usually that has Listeria monocytogenes in it, it can be transmitted from the mother across the placental barrier and infect the fetus. And that can cause miscarriages, premature deliveries, and severe neonatal infections, including neonatal meningitis, for which we have no vaccine against. So that's why our main mitigation strategy is simply to just avoid eating those foods during pregnancy. In terms of diagnosis, we can culture this organism from blood, CSF, other specimens, and these colonies here, you can't really see that zone of beta hemolysis around those, but they do produce some hemolysins. In terms of stats, the stats I pulled, about 1,600 people in the United States get listeriosis every year, and only about 260 people die. So that's not a huge amount, but something to be aware of. There was a significant outbreak that happened about 10 years ago, 2015, a pretty famous outbreak of listeriosis associated with Bluebell ice cream that resulted in one of the biggest settlements in US history for a foodborne outbreak, multi-state outbreak. We had cases popping up in 4 states, Texas, Arizona, Kansas, and Oklahoma, that were eventually linked back to people who were consuming ice cream made from these production facilities on this map, where they had, as investigators revealed in a couple different reports, poor standards of hygiene in those facilities. They weren't cleaning out equipment adequately. So this organism, Listeria, was getting into the ice cream. And ironically, a couple people in at least one of those states, I can't remember which state, contracted the disease while they were hospitalized and they were being fed ice cream at the hospital. So this outbreak did result in deaths. Anytime an outbreak results in more than just illness, if you have deaths associated with it, the losses can be ginormous. So this one had a $17.25 million settlement in connection with the contamination of that ice cream that was distributed to multiple states, including military facilities as well. So that was in, I think, Texas. So. But Bluebell, you'll be happy to know, is recovering and they've done well in solving that problem, and their products are still on the shelves, so. Okay, so Corynebacterium diphtheriae. The only reason why we don't put this one next to something like Streptococcus pyogenes, which causes strep throat, is because of the fact that it's a gram-positive rod, right? So gram-positive rod, but it actually, at least to my mind, behaves in a way that's similar to strep pyogenes. And it's also kind of similar to me to whooping cough, because it's a disease it's associated with pediatric populations, and it's also been, the numbers have been steadily diminishing over the last couple decades. This is the final target in our Tdap DTaP vaccine. This is the D, diphtheria, where that vaccine has the diphtheria toxin deactivated into a toxoid and formulated into that vaccine. We used to get a lot of cases. This graph is just showing the decrease in cases reported starting from the early 1920s. So this would have been a pretty early vaccine in the US. But cases dropped down to essentially nothing. One of the last cases that I saw reported was 2004, almost 20 years ago. And then, that was a pediatric case. And then last year in Florida, an adult got diphtheria. Extremely rare. So we almost never hear about this in the US anymore, but virtually wiped out. Where this is mostly a problem still is in the developing world, where they don't vaccinate their populations routinely, and you still get cases of diphtheria. In terms of morphology, it has a distinctive club-shaped palisading morphology. Because of that, you can sometimes call bacteria carineiform if they have this palisading morphology, but this is not the greatest picture in the world. But yeah, palisading morphology, where they stack together, these rods stack together like, almost like lumber stacked together. Many of us probably are colonized with Corynebacterium diphtheriae. We have it on our skin, oropharynx, GI and GU tracts. It's unusual for a gram-positive rod to colonize the skin like that, but they can do that. Transmission is primarily through aerosols. You breathe it in. You can also, so for somebody who is carrying it, you can also be infected with your own endogenous flora, your own Corynebacterium diphtheriae as well. But again, mostly because of the fact that we're vaccinated, we self-see cases. In terms of pathology, there are two different major presentations. One is much more common than the other. Respiratory diphtheria is what it's known for, but it's not really affecting the lungs so much. So remember when we were talking about Streptococcus pyogenes and strep throat, and the fact that coughing is not associated with that because it's a throat infection. With this too, with these symptoms, sore throat, mild fever, malaise, and hoarseness, you don't see coughing because it's not a respiratory tract infection. It's affecting the epithelial cells in the back of the throat, like the uvula, the palate, maybe tonsils, those types of tissues back up, potentially all the way up to the oropharynx and the larynx, but not the respiratory tract itself. What happens here is we have the production of this diphtheria toxin, which is a phage-transmitted toxin. Strains without it don't cause disease at all. And this diphtheria toxin causes that necrosis in those affected tissues. This necrosis, like you can see in the back of this woman's throat, this is a 39-year-old woman who had diphtheria. This is 4 days after she originally had these non-specific symptoms of fever and malaise, but you can see that kind of grayish membrane that's forming over the back of her tonsils and uvula. That is classic for diphtheria, classic sign of diphtheria. That membrane is just a collection of dead and dying cells, bacterial and that person's own epithelial cells. There'll be some neutrophils in there as well. And that membrane is so closely adhering to that skin that if you pull that back, oftentimes it bleeds a little bit. Where this is really troubling with kids is sometimes that pseudomembrane can become dislodged and it can become lodged in their airways and cause suffocation. So that's one of the ways that historically kids could actually die from diphtheria. The other presentation, which is even less common, is cutaneous diphtheria. As I said, this is a skin cancel, so if you have a wound or a break in your skin and this bacteria gets in and it's producing this toxin and you're not vaccinated, you can get the same kind of presentation where you have a pseudomembrane on this wound that's associated with Corynebacterium diphtheriae. Usually that is a localized infection to that wound and you won't get systemic effects with cutaneous diphtheria. Actinomyces species, these are misnamed because they have some fungal-like characteristics, but they're definitely bacteria. definitely anaerobic and normal colonizers of the upper respiratory tract, GI, and female genital urinary tract. A bunch of different species have been identified of actinomyces. Most of them do not cause us problems. Actinomyces israelii is probably the most virulent one, and even that one doesn't have a huge number of virulence factors. So these are fairly low virulence. They don't really have any evasive capabilities, but what these infections are associated with are things like trauma, dental procedures, which you have these in your mouth, so when you have dental procedures, sometimes they get into your soft tissues that way, and poor oral hygiene. The organisms have this kind of characteristic sulfur colony production, sulfur crystals associated with them. This is what one of those sulfur crystals look like. You can pick this out of somebody who has, who's presenting with actinomycosis. They have these sulfur crystals. These aren't actually sulfur, they just look like sulfur crystals. They're like a yellowish white crystalline substance. And diagnostically, you can crush them in between glass. You can actually crush those little granules together and then look at them microscopically, and this is kind of what they look like. You can see the filamentous bacteria coming out of that crushed sulfur granule. If you actually grow up the bacteria themselves under and stain them, they have this spidery type look to them. It looks fungal and filamentous, but it's bacterial. And the colonies themselves have a very distinctive morphology. I didn't put a picture in there, but they look like molar teeth. They have this, like they'll grow up vertically away from the plate and look like molar teeth. Very distinctive appearance. A couple different presentations here. The most common is the cervical-facial infection that you get. This is the one that's commonly associated with dental procedures and trauma type base. What happens here is bacteria are able to get into mucosal surfaces underneath where they wouldn't normally have access. And then they can eventually make their way into lymphatic tracts and start forming these sulfur granules. Not a lot of significant mortality associated with this, but when the sinus tracts are infected and you see sometimes open, like these open granules in this person's face, like this guy's mandible has a draining sinus tract right there, you would want to treat that. This is a cartoon, but you can kind of see how many sinus tracts are affected and the fact that some of them are starting to open up with that infection. This is called lumpy jaw. You have that many sinus tracts opening up. There are other sites that have actinomycosis, the ability for it to develop actinomycosis. Thoracic actinomycosis, where you get abscesses in lung tissue. That would probably be pretty difficult to diagnose. And by the way, if you do culture these organisms from one of these sinus tracts, it takes a very long time to grow them up. It could be 2 weeks to grow these things up. You have abdominal actinomycosis, where any number of the organs in the abdomen can be affected, abscesses. Pelvic actinomycosis. This picture at the bottom here is showing an IUD, like an intrauterine device being pulled, that was pulled out from somebody who had actinomycosis in the pelvic area. So it has this ability to kind of form a little bit of biofilm on these medical implant devices as well, cause a problem there. And lastly, with the CNS, these are extremely rare, but you can get cases of meningitis and encephalitis associated with actinomycosis in the CNS as well. Treatment for this, prolonged antibiotic, it takes a very long time to clear this with antibiotics, but prolonged antibiotic administration and then if necessary debridement or drainage of those sinus tracts. Right, and then the last couple slides, I don't want to say these guys are no big deal, but these are some of the least virulent bacteria that we've talked about in this entire block, so we'll finish off with some of the light friendly ones. Cutibacterium acnes, formerly Propionibacter, reclassed in 2016. This is a very common skin cancel, most of us have, I don't know, probably all of us. It has the dipteroid morphology appearance and gram staining. What it does primarily when it causes acne is it stimulates, it releases some bacterial peptides that stimulate inflammation. And that causes a little bit of bacteremia temporarily at that site and inflammation from the host. So you get apnea as a result of that. It also produces some of these invasive enzymes that might disturb the tissues around hair follicles and these sebaceous glands. On your slide, just out of curiosity, was apnea misspelled? Did it have an extra E in there? Okay, alright, sorry about that. Right, then we have Lactobacillus species. Anybody ever heard of Lactobacillus species before? Yes, okay, what do you associate Lactobacillus with? Yogurt, yeah, primarily. So this is one of the primary probiotics that we use. Oftentimes we see it on yogurt containers, oftentimes live cultures, Lactobacillus. It's considered a very beneficial bacterium. Lactobacillus, if you ferment lactose, and then one of the primary species, one of the main species, is Acidophilus, so acid producing. It's associated with keeping the pH nice and low in areas where it colonizes, like the vaginal tract, for example, low pH because Lactobacillus is one of the predominant organisms in the vaginal tract. It also has a big responsibility for maintaining the integrity and the balance of bacteria wherever it's colonizing, good bacteria. So when you have a dip in the populations of Lactobacillus, particularly in the vaginal tract, that lends itself to situations where you're getting overgrowth of some of these more virulent pathogenic bacteria that may also colonize the vaginal tract, but they need to be kept at low numbers. So Mololuncus, Prevotella, Gardnerella, those are the three genera of bad vaginal bacteria that need to be, whose numbers need to be kept in check by Lactobacillus. So it's more like a good, if you have Lactobacillus that's associated with like a nice healthy gut or genital urinary balance of bacteria. Occasionally, in people who are immunocompromised, it has been implicated with transient bacteremias, endocarditis, and sometimes even septicemias, but that is extremely rare because of the fact that it colonizes just about everyone's like genital urinary tract, the urethra on most people. When you're collecting urine specimens, like from people who are submitting urine specimens, it is oftentimes cultured from there, so you have to be able to interpret that as a contaminant, which it usually is. And also, mostly with that as contaminant in urine cultures. So it poses a little bit of a problem for interpretation, but very seldom is it actually a problem itself. And then lastly, we have Bifidobacterium species. This is also a colonizer of the vaginal tract and the mouth, but where it's most important is in the gut. I don't know if I showed this graph earlier when we were talking about the gut. I don't think I did, but it has the distribution of different important species and genera in the GI tract. And as you can see, Lactobacillus and Bifidobacterium both are predominant species in the gut, and they both work to keep the gut healthy. So both of these are extremely important for maintaining gut health. This is another key probiotic in a lot of different probiotic foodstuffs. It too, even though it has a low virulence potential, it too has sometimes been implicated in disease, like it's the only bacteria that can grow out of specimens. But in order for that to convince anyone that it's actually the etiology of disease, you have to repeatedly isolate it from multiple different specimens in large numbers before you would suspect it's actually causing pathology itself. And there, I don't know if you can see this, the font is a little bit small, but on this yogurt container, Bifidobacterium lactis BB12 strain, it's one of the live culture ingredients, Lactobacillus rhamnosus, Lactobacillus acidophilus, Bifidobacterium brevi, so a bunch of those different probiotic bacteria are on there. The name Bifidobacterium refers to that bifurcated morphology on those bacterial cells, very distinctive, like split into two forks. And that is it. So, any questions for me about this deck? Okay. So going forward, we will meet again for review on Tuesday. My leave just got approved yesterday, so I'm flying out tomorrow morning and I'm coming back like at midnight, Monday night, before your review. So it'll still be a good review, hopefully I'll have some time to put it together, but on your end, since you guys do not have a test on Tuesday, make sure you come to your review, having invested some time in studying those decks. You can shoot me texts or questions, I'll be checking email as well, but I will also be busy during that time period, so I might have a slower response time. Yeah, okay, that's, yeah, right.
So can we expect on the examination for any abbreviations of genus or species, or are you gonna completely lay it out so we see both names?
That's a really good question. So as it is now, for example, if there's something like, if we're talking about EPEC, at least in the early questions that are asking about that, it'll be fully spelled out, anaerobic pathogenic, Escherichia coli, parentheses, EPEC. And then if that's like question 1, and I ask about it again later, it might be abbreviated as just EPEC, but that would only be if it's already been spelled out elsewhere.
So for example, we talked about the, like Katana, one with phylos.
Yeah.
So if that's the question, the options will have the full name, genus, species of different bacteria. Or would you abbreviate the genus?
Oh, yeah, so abbreviating the genus I seldom do, and I'm not gonna say B. Quintana, it would be Bartonella Quintana, yeah. In terms of associating it with common nicknames though, so with Bacilliformis, for example, Bartonella Bacilliformis, you might be asked, it would be fair game to be asked what disease is associated with, like the chronic phase of Bartonella Bacilliformis, and you'd have to know that that was really a fever, or you could say the Parowana verruga. Cat scratch disease, common name, you'd have to know that that was associated with Hansella, Bartonella Hansella, stuff like that, yeah. Abbreviations for things like LT, ST, you might have to contend with those abbreviations, but they would be in the context very clearly that we're talking about toxins, diarrheogenic toxins. And most of the time when I talk about toxins, I will spell out like the full name of the toxin. Any other questions? Okay guys, well, have a wonderful 4th of July weekend. Remember that Campbellback cases spike over the 4th of July because of undercooked chicken and barbecues. So
Don't enjoy it.
but enjoy it. Have a great time. Go on Tuesday.
Wash your chicken.
Don't wash your chicken.
Yeah, but.